Good afternoon. This is Dr. Benjamin Domb from the American Hip Institute in Chicago, presenting a debate from the American Academy of Orthopaedic Surgeons, delivered at the Combined Specialty Day of the Arthroscopy Association of North America and ISAKOS. This debate centered around a 30-year-old male with Tonnis 2 early osteoarthritis and FAI. And in this debate, my assignment was to argue for arthroscopic osteochondroplasty and labral repair or reconstruction is always better. My disclosures are listed with the Academy of Orthopaedic Surgeons. Our moderators in this debate were the esteemed surgeons, Dr. Christopher Larson and Dr. Vikas Kanduja. And my opponent in the debate was the eminent surgeon, Dr. Femi Ayeni from Canada. In this case, there was a 34-year-old wine merchant and climbing instructor with a painful left hip over 1 year, worsened with activities requiring deep flexion and rotation. Pain is constant, affecting his activities of daily living, and moderate in severity, 6 out of 10, with mechanical symptoms, no significant medical history. General exam was unremarkable. Trendelenburg test was negative on both sides. He had flexion to 90 degrees, internal rotation at 90 degrees of flexion was 10 degrees, and external rotation was 40 degrees. He had positive impingement and Faber tests. The x-rays are seen here, and these show the joint space is relatively intact. However, there's a large cam lesion seen especially on the AP view, meaning it's a superolateral and posterolateral cam lesion, and perhaps some early sclerosis of the acetabular rim. Here on the MRI, we can see a labral tear anterosuperiorly and some early changes in the acetabulum on its edge near the labrum, where there is some edema and perhaps some early cystic change visible on the MRI, but not particularly visible on the X-rays. And CT essentially confirms the bony deformities previously described. The assignment in this debate to argue for arthroscopy is up against a challenging adversary in the hip replacement, in that hip replacement has been called the operation of the century by the Lancet and is perhaps the holy grail of orthopedics. Having said that, Neil Gershenfeld said, give ordinary people the right tools and they will design and build the most extraordinary things. And so we aim to build something extraordinary in this hip using the arthroscope. So we should start by considering whether this really is a Tonnis 2 hip. If it is, there are limited indications and benefit of arthroscopy in Tonnis 2 hips. We've previously shown that in our research from American Hip Institute. So my adversary, Dr. Ayeni, may be thinking he has won the debate, and perhaps he has. But if we reconsider this question, is this really Tonnis 2? And where does it fit best in the classification? The joint space is intact. There's minimal sclerosis. There are no subchondral cysts visible on X-rays. Perhaps they're visible on MRI. And maybe there's an osteophyte versus a primary cam lesion. So overall, this may actually fit better into Tonnis grade 1 rather than Tonnis grade 2. And if it does, we've shown in our research excellent outcomes in Tonnis grade 1. But having said that, there is nothing easy about this case and much that has to be gotten perfectly in order to get a great result. So to achieve a great pain-free hip in this case, we need a precision FAI correction. We need a meticulous restoration of the labral seal, probably with a reconstruction. We need to treat the chondral defect, likely with a microdrilling, and we need meticulous preservation of the capsule and repair of that capsule. Here's why. We know that labral preservation is crucial. Labral repair has been shown to be superior to debridement at short and long-term follow-up. Since the labrum is likely irreparable in this case, we're fortunate to have labral reconstruction, likely using the knotless pull-through technique, which is a durable option for the irreparable labrum. We've previously shown 87% survivorship at 5-year outcomes and shown clinical outcomes in the irreparable labrum, which are comparable to a repairable labrum if we get a good reconstruction. We have to cure the FAI. Cam deformities are associated with higher grade cartilage damage, and inaccurate femoroplasties lead to lower survivorship and outcome scores. So an optimal femoroplasty is necessary, and we've shown that optimal femoroplasty can actually change the natural history of FAI in a favorable way. We've also previously described the technique to achieve a perfect spherical femoroplasty, and this utilizes concomitant arthroscopic and fluoroscopic visualization throughout the procedure to get a perfect sphere. In terms of the chondral defect, we've shown excellent survivorship with microfractures. At 10-year follow-up, the survivorship has approached 80%. And fortunately, we haven't had many opportunities to have second looks, but in those we've had, we've seen excellent fill of the defect with fibrocartilage, as you see in this before and after picture here. These results of microfracture have been true even with larger chondral defects, greater than 2 square centimeters on the acetabulum, and even with focal femoral head damage treated with microfracture. So none of these things by themselves is a contraindication to arthroscopy in light of the evidence. Finally, higher survivorship has been seen with capsular repair or plication, hence capsular management does matter. And lastly, age is on our side in this case. Our data has shown, as previously published, that in the group under 30 years old, there was a 98% survivorship. So again, nothing easy about this case, and it's an excellent case, a well-chosen case. But it's a young patient, arguably with Tonnis 1 changes, who likely requires a precision femoroplasty, labral reconstruction, microdrilling of the acetabulum, and capsular closure. And if we do all those things and do them perfectly, we can expect an excellent prognosis and an ability to preserve the hip, which leaves my opponent frowning. And this is his face when he realizes that he has, in fact, lost this debate. Thank you very much, and greetings from Chicago.